this. Most of your patients when they come in are kind of like this. We knew everyone would sit up straight. So again, like you kind of can talk to them at first about that, especially with the subacromial impingement, how you pull the scapula back and you can see that they have more range of motion and less pain. But just in terms of posture, working on getting the shoulder blades down and back, and then getting the chin tucked a little bit more. So you're trying to kind of elongate this area of the neck and then get the shoulder blades down and together. So as an exercise, we kind of do the scap sets where we're pulling to an extreme range and then relaxing, but obviously functionally, they're not going to be doing that when they're walking around all day. So what I'll tell them is if that's kind of like a 10 out of 10 contraction, they're doing their maximum, just do a tiny pinch to slightly engage the mid and lower traps. And then that will basically open up the front of the chest. A lot of the patients also have tightness in the pecs because of this position over time. I'll show you a stretch for that. And then for the neck, it's DNF, deep neck flexion, that we do a lot of work on. So you can do this in sitting where you're literally just kind of tucking the chin and relaxing, and tucking and relaxing, so we're making a ugly double chin. But that's kind of the motion that you want to do. And then I also give them a cue if they think of a string kind of pulling them towards the ceiling, like you're just basically trying to elongate everything from there. So we'll do some postural work that way. So the scapular exercises that we kind of have on the sheet are the scat sets that I already showed you. Yeah. So the cueing, like I said, you could use your hands to kind of facilitate down and together, but you really want this to stay soft. So if they're contracting it and they're feeling it up in the upper traps, you really want to make sure that they're doing this properly. So if they leave your office and they see us 45 minutes later and we've been doing this, it's like, I have neck pain now too. So just make sure that they're not using the upper traps. And so for women, I'll just say, think about where your bra strap is and kind of try to pinch down there, or try to sink your shoulder blade into the opposite pocket down here and squeeze those together. The other, yeah. So this one, can you see that? So basically, I'll just kind of show you. The arms should be flush with the wall, their elbows and their hands, and they're engaging that scap set that we just talked about. So they should only be going as high as they can without starting to shrug their upper traps into the motion. And this will help them start to kick in some of those mid and lower stabilizers of the shoulder blade. And I'll do maybe 10 to 15 of these, but I just want to make sure that they fill in the correct space. And the wall is just a nice cue because they have to keep everything flush with it. So I think that picture might be on there. Is that one of the ones that we had a hard time finding? Okay. There's also one that you can do facing the wall, but I didn't add that in just because I feel like that they have a really hard time not shrugging into this exercise. So I think we're probably safe just doing the wall slide facing away. And then the sleeping posture, this one's huge, I think, for shoulder patients. So a lot of them are not sleeping well, they have pain at night, so they're cranky and they're in pain. So say if they had a left shoulder dysfunction, and I ask them a lot about how are you sleeping? You know, are you a side sleeper, are you a stomach sleeper? And a lot of the time, if they're side sleepers, I'll have them sleep on the opposite shoulder, and then put a towel under their arm, because this opens the shoulder joint a little bit so it can give them some space and hopefully decrease their pain. It's got to be a fairly, you can double a pillow in half or do a towel. A pillow I think works better because you can kind of put the whole arm on it. If you think about a sling, it sort of holds them in that open pack position as well, and that's an area that is usually a lot less painful than having it close to the side. I even had a therapist that used to have patients wear a collared shirt to bed with a pocket, and they put golf balls in it so that if they fell asleep and started rolling onto their stomach, it would they'd roll off of it. So that's a little extreme, but if they're stomach sleepers and it's really painful, that's a way to keep them off their stomachs. And the other one is if they're on their back, you can have them put a prop under the elbow just to kind of get the humerus to go back in the joint a little bit instead of them hinging forward, and then under their stomach, so it's kind of this way. Pendulums is supposed to be a very passive exercise, and it's almost next to impossible to have patients completely do this exercise passively. For any of the pathologies I talked about before, it's not the biggest deal if they're activating their muscle. Usually we're more concerned about that if they've had an operation and they're not supposed to be contracting their muscle. So for the pendulum, you'll have the patient lean on the table with their non-involved arm, and then their other arm is kind of dangling. So they're supposed to basically be using their body to sway the arm. So it should be totally loose to the point where if you hit it, it just starts to do its own thing. So you'll see a lot of patients that are like doing this sort of thing instead, and most likely that's what most of the patients are going to show up doing. I don't have a problem with that. I think the traction really helps actually with pain, and if we can just get them moving a little bit, that can help the pain a lot. So I'd say the most painful patient that you're not sure what to do with, that would be a really good exercise to at least start them on for range of motion. Doing an exercise where you're helping with the other hand, and then kind of pulling that arm through, and then coming back down. So gravity is assisting a little bit with that. They'll usually get a lot more range when they're laying down doing this motion than when they're standing up, because they're having to pull their arm against gravity. And then again, cueing them to keep that shoulder blade down, because we're more concerned about the quality of motion than quantity of how many degrees they're getting, especially if they're kind of hiking and causing this other, the poor mechanics with their range of motion. And we had table slides. So this one, the patient, actually this is really good. So they can just sit at the side of their table with a towel. And this allows them to kind of glide the arm in an active range of motion, but it's somewhat supported. So they can go into flexion this way, they can go into abduction, kind of push out. They can go in circles if they're standing up. So again, just a way to get the arm moving to get some range of motion. And then the last challenging, so if they've got better range, if they're able to actually keep their shoulder down, they can start to do a lean into the wall to stretch. Maybe this is a piece of capsulitis patient that came in to see you and they're now, in the thawing phase, so you want to get them into that higher end stretching, but again, making sure that their shoulders are down. And then lastly, to just get into an active range of motion, keeping the shoulder blades down, so they can do just arm lifts here. And if they can only get to here without raising the shoulder blade, that's fine. You just don't want them to start getting into this sort of thing. Really the end range stretches, so the dowel stretches, it's again using a stick. You can go into external rotation with that. So with the adhesive capsulitis patients that have no external rotation or very limited, this is a good one to get them started on. So let's say the left shoulder's the one that's tight. You basically have them press and hold. And generally with stretches, I do the 3 sets of 30-second holds 3 times a day. And then the internal rotation stretch is, this one's a good one with the towel. So for left one is the one that's restricted. A lot of the time they can't even get past here. You'll have them grab a towel and then they can kind of start to pull their arm to where they can hold it. And then 3 sets of 30 seconds for that one. This one's generally pretty painful. That's normal. But I tell them as long as once they come out of it and kind of shake it out, if it's no worse, then that's an okay exercise for them to do. If they feel like it's gotten really flared up just from going into that motion, then I probably wouldn't give that to them. Lastly is the pec stretch. This is a very important stretch because everybody's gotten so tight in that poor posture. So you can do this in a doorway or you can do it in a corner of a wall. Yeah. But basically have the patient kind of put their arm, if this is the doorway, and then step through, and they should feel it all through here. So they can do both at the same time, or they can just do the same side. And that's